Good afternoon, everybody. It's once again a privilege to be speaking to you today as part of the Mexican Urologic Oncology Symposium. It's a privilege to participate in this meeting, and I do send my very best wishes to all of you throughout these challenging times. The talk I'll be speaking to you at this point is really discussing and highlighting what the role of cytoreductive nephrectomy remains now in 2021 for kidney cancer. I have no relevant disclosures pertinent to this topic. I do serve on the NCCN, bladder and peanut cancer, but it has no specific relevance to this as well. I serve as the president of the Global Society of Rare GU Tumors. So firstly, before we embark on where we stand in managing metastatic kidney cancer in 2021, I think we just need to highlight the way we look at our patient population today. We know that previously the Mozart risk groups were defined, and really were defined based on whether or not patients had a nephrectomy, their performance status, hemoglobin, calcium, and lactate dehydrogenase. Subsequent work has highlighted that many of those same factors, but as well some of the additional serological markers, help define and really fine-tune these criteria, particularly in the current era of immunotherapies and current systemic therapies. And those are referred to as the IMDC or the HANG criteria. As you see well here, this allows us to stratify patients, and importantly, clinically, it has high relevance because it helps us determine ultimately when patients should be tailored to receiving systemic therapies, for example, such as in the poor or intermediate high volume group, or in patients who have favorable disease and ultimately where cytoreductive nephrectomy still has a role in our current era. So again, these criteria really, and you see the similarities and differences here between these two, are really critical for us to be familiar. And really, whenever we see a patient with metastatic kidney cancer, that we consider using these. So let's talk a little bit about what we're noticing in recent years. So this is an older study just published close to 10 years ago in Urologic Oncology. But it really showed that there was really clear decline in the number of patients undergoing cytoreductive nephrectomy, about 38% back in 2008. And some of the factors that predicted this decreased use of cytoreductive nephrectomy were ethnicity, age, and the onset of the current era. And we'll talk about those trends have continued and probably significantly increased in recent years as well. You see this really well depicted, again, using SEER data, most recently in that 2006 and 2008 within the study population. And you also see an important factor, which is when you start looking at some of the larger studies, you see that the number of patients undergoing cytoreductive nephrectomy really is fairly small, anywhere from about 60 to 70%. And this is an older publication back in 2018. So let's talk now about two trials which I think have been paradigm shifting in terms of the use of cytoreductive nephrectomy in the current era. These are the CARMINA and the SURTAM trial. So as you all know, this is the CARMINA trial, the way it was designed, 450 patients stratified really to Sutent alone or cytoreductive nephrectomy followed by Sutent. And really you see these study groups were really fairly well matched in terms of their age. Again, importantly, these are intermediate and poor risk using the criteria Memorial Sloan Kettering or Mozart criteria. Performance status, again, 0 to 1. And then when you start looking at specifically at the cohorts, you see some differences. For example, higher incidence of patients with T3 and T4 disease in the combined treatment arm, and a higher preponderance of patients who had bulky nodal disease and received cytoreductive nephrectomy arm. So although they're fairly well matched, there are some subtle differences that you see here as well in terms of the sites of metastases within these cohorts. These are the breakdown of randomization between patients, and you can see here again in the group that got specifically cytoreductive nephrectomy and Sutent, about 40 patients did not in fact receive Sutent, and 165 events or deaths occurred. In the group of patients that received Sutent alone, you see here 161 deaths occurred. So when you look at the overall survival, you see really no differences. Progression-free survival, once again, maybe in fact a slight improvement for the Sutent alone arm. And when you look at it as a whole, you see complete responses, again, fairly low. And for the most part, really no significant differences between the two groups. And if you look at clinical benefit, a slight probably favoring arm of 47.9% in the Sutent alone arm. Treatment-related toxicity, again, somewhat similar. Most of the toxicity related to Sutent, and the typical ones you would expect, again, hand, foot, inflammatory changes. But for the most part, these were fairly low-grade toxicities that were associated in both arms. Now, let's talk a little bit about the SIRTIME study. SIRTIME study, again, same thing, using targeted therapy. So again, not using immunotherapies, which we would define as current most commonly used agents we use in advanced kidney cancer. And really, again, study was 2 arms, either immediate surgery, progression status was assessed 4 weeks after nephrectomy, and then patients went on to receive targeted therapy using Sutent for 4 cycles, versus deferred nephrectomy for 3 cycles, then they underwent nephrectomy, and then 2 additional cycles, and patients were then reassessed at 28 weeks, and then subsequently every 12 weeks. Important thing about the SIRTIME study, it was probably significantly underpowered. The study itself was to accrue close to 530 patients. In fact, only accrued 100 patients or so. And in consequence to that, you see that it probably did not necessarily achieve the statistical power to look at the endpoints that it needed to in a meaningful way. That being said, when you start breaking it down, again, you see deferred and immediate, really no differences in how they did in terms of progression-free and overall survival. Again, with deferred arm probably doing slightly better in terms of overall survival. So there were subsequent publications from this looking at systemic therapy in the role of cytoreductive nephrectomy. This is a publication that published in European Urology, again, looking at and combining a lot of this data. And again, at the end of the day, really finding no significant benefit to cytoreductive nephrectomy as a whole. You also see survival after cytoreductive nephrectomy in patients with metastatic non-clear cell RCC. You clearly see that patients as a whole clearly have underwent cytoreductive nephrectomy over time, has significantly decreased. And in fact, what was interestingly enough found in this, there was a benefit to cytoreductive nephrectomy, which was demonstrated in patients with certain histologies, particularly non-clear cell histologies specifically. And you also see here patients who had no cytoreductive nephrectomy, probability of cancer-specific mortality was much higher in patients who had no cytoreductive nephrectomy. Same thing was seen here in patients with, as a whole, with non-clear cell histology. So it's important, that being said, when you look at this data, to understand there is some level of selection bias that's going to take place in the selection of patients who are ultimately undergoing surgery. And again, in terms of 24-month cancer-specific mortality risk in patients with these non-clear cell histology, again, you see a higher risk of cancer-specific mortality in the no cytoreductive nephrectomy arm versus in the patients who in fact had cytoreductive nephrectomy. Definitely an interesting observation. So how would we sort of summarize this data? Well, I think there is several observations which are very clear. There probably is really little to no survival benefit to cytoreductive nephrectomy in many patients with intermediate to poor risk disease up front. I definitely think that these studies were using what we would really define as not standard of care or best therapeutic systemic options for patients today. And again, based on that, how relevant is this data in the current era that we're in really can be debated. No question, it didn't look at patients with good risk disease, where I think there definitely needs to be discussion of cytoreductive nephrectomy. And no question, I think, as we all know, genomic profiling is going to revolutionize the better selection of patients versus conventional histology. So better understanding which patients with certain genomic profiles are likely to have a pattern of disease which is more confined to the organ versus spread of the disease. So this is some data from our group that we've looked at, looking at, again, based on the number of sites of disease. No question, and these are among patients that underwent cytoreductive nephrectomy. If you only have a single site of disease, no question, the greater benefit to cytoreductive nephrectomy. Again, histology, we didn't see much of a difference. Again, there is probably some element of lack of power when you look specifically at smaller subsets of patients. And we did publish this work as well just a few months ago in Frontiers of Oncology, but no question, patients who have sarcomatoid histology, for example, definitely has less to no survival benefit from upfront cytoreductive nephrectomy. So if you know, for example, a patient has sarcomatoid variant, in the setting of metastatic disease, I think there's great pause ultimately to do an upfront cytoreductive nephrectomy. That does not mean to say if a patient has a favorable response to systemic therapy for a period of time, proceeding with surgery may not in fact be beneficial. In the setting of tumor thrombi, and that's always an active point of discussion, is that a patient has a tumor thrombus in the setting of metastatic diseases, it makes sense to proceed with surgery. Probably the burden of disease makes a lot of sense to consider. Patient's obviously performance status, patient's expectations, patient whether or not they're symptomatic, that clearly are things to consider. I definitely think some of the combinations of IOs today, such as Nivo/Ipi, have been ones that we've seen some very encouraging results, even in the setting of tumor thrombi. And as we were discussing previously, some sites of disease we no question know do better than others, like lung, for example, doing more favorable, but similar things like brain clearly being adverse prognosticators. And again, stratifying our patients by these risk groups, no question makes a lot of sense. The way I have also done some research and in the process of publishing some work looking at doing cytonephrectomy, not so much from a survival endpoints, but really from a symptom management standpoint. And I definitely think there is definitely some value and thoughts related to doing it in that specific setting. Additional thoughts, I think there are some really interesting novel studies currently being conducted, which I think are things that we need to be aware of and hopefully we'll be reporting out probably in the next 2 to 3 years. Some of these are such as the Nordic Sun study, which is a phase 3 study of 400 patients, with patients are getting Nivo, ipilimumab, so conventional treatment, plus cytonephrectomy, looking at overall survival. That'll be reporting out in 2025. The PROBE study, a little bit different study using standard first-line therapy plus nephrectomy, and really using an overall survival. This is more in progress at this point. And the cytoshrink study is in fact looking at not so much cytonephrectomy, but stereotactic radiotherapy in a setting of Nivo/Ipi, and trying to see if there's value of considering that for local consolidated treatment versus immunotherapy alone, and definitely more to come that we'll be reporting out hopefully within the next year and a half or so. We did publish this work a few years ago in Journal Urology, looking at various tumor thrombi and really showing that clearly patients who have tumor thrombi above the diaphragm probably do worse in the setting of cytoreductive disease. And again, looking at it as a whole, we're able to stratify patients based on these in terms of the benefit they likely will have from undergoing surgery. And see, these are some of the factors we looked at, the strongest, again, being sarcomatoid. So you see a recurrent theme here. The sarcomatoid variant clearly is an adverse prognosticator. I definitely think the role of deferred cytonephrectomy, particularly in treatment responders, is definitely something which has great relevance. And this is a paper that was just published a few months ago as a multi-institutional IMDC study. And really what they're able to show in this study quite well is that, doing a selected cytonephrectomy in patients who do have some level of response clearly has a benefit in terms of survival and treatment failure-free survival as well. And this is also a nice abstract that was just presented at ASCO GU last year, really looking and doing more a propensity type score match analysis, really to try to better tailor patients who may benefit from cytonephrectomy. You see here comparing immunotherapies and targeted therapies, you clearly see here that patients in the previous era probably had less of a benefit to cytonephrectomy versus today. No question, I think there is reinvigorated enthusiasm that immunotherapies are a game changer, particularly in combinations in these patients. So which patient should we operate on? Clearly symptomatic palliation, if that's the end point, definitely there may be a role, particularly in patients who have a better performance status where the burden of disease is less. In good risk and select intermediate risk patients and patients who have a good response to systemic therapy. And I think there's no question there is probably some consideration where the volume of disease is. If it's predominantly confined to the kidney, that may make sense. And there is no question that it's a tri-fold consideration, the patient, physician, and tumor-specific characteristics. And last but not least, I just want to highlight that really, as a whole, I think our approaches have not changed. This is a new editorial I'd written just a few years ago, but really you see that even in 2015, I think we had an approach which is very similar to today, favorable risk of upfront cytoreductive nephrectomy, and although IL-2 and others are not current ones we consider, Immunotherapies, no question, may have a role in these patients. In patients with poor risk, no question, upfront systemic therapy. And in the intermediate risk is where really there's more of a discussion in terms of cytotoxic nephrectomy versus systemic therapy. And again, based on the host of factors. And really that's where multidisciplinary care and tumor board conversations are critical. So last but not least, I leave you with this quote. I think that the good physician treats the disease, the great physician treats the patient who has the disease. So tailoring our approaches based on the characteristics of our patients, of the disease, and ultimately what we feel are going to be the best, particularly in our hands, is critical in caring for our patients. Thanks again for your attention and very best wishes to all of you, and hope to see you in the months to come. Thank you.